All right, everybody. We can get started because Bill's here. And thanks everybody for coming. We're going to go over femoral shaft fractures. And as always, if you guys want to interrupt me, correct me, say I'm wrong or stupid, anything you want to say, give us your experience, please feel free to interrupt.
I think this is the highlight of my month.
Really? Me too, actually. I enjoy seeing it. I enjoy just the camaraderie of seeing everybody. So we'll go over femur fractures. So femur fractures are very common. 1 in 10,000 people get it, which is pretty high incidence. And it happens in less than 25-year-old, usually men, and greater than 65 years old. So the less than 25-year-olds, those are the crazy, like, college kids on motorcycles. That's what I figure, or like whatever, car accidents, things like that, sports. And the highest incidence is in motor vehicle crashes, motorcycle injuries, people struck by automobiles, aircraft, which I've never seen an aircraft injury because I guess they go to trauma centers, and gunshot wounds. And the other most important thing is it's a high level injury. So the femur is really big. You can imagine, say that car, how much energy it is to get, in a car accident, and it's transmitted to your femur. So the most important thing for us to remember is that some other system may be involved, and you have to have a high index of suspicion to ask for help. So it could be a neurological system like a spinal cord injury, spine, brain, vascular injury, abdominal injury, lung contusions are most common. So this is just so we can reminder of what the femur looks like. It's very long, it's very thick. On the very back of it, there's the linea aspera, where I think most of the gluteus maximus inserts, the large thick tendon. It's fed by medullary vessels, so anybody who's done a femur, open femur with a plate, knows that there's these big feeder vessels that enter the midshaft, which can bleed terrifically. And they're nutrient arteries. So 2/3 of the blood supply comes from these arteries that go into the bone. And the other most important thing to remember is it's got a bow. So you see on the side view, the femur has a anterior bow. So you always forget that. You always think it's straight until you put the femoral nail out the front, and then you remember that the femur has a bow. We'll get into that. So in the thigh, there's also a big artery. So just for a view, aorta ends in the iliac, and then it goes external, internal. The external one goes into the thigh. At the inguinal crease, it becomes the femoral artery, and then the femoral artery goes basically to the thigh and leg. And this is just a view of the profundus. So the first branch of the femoral artery is the profundus femoris, and that basically supplies the whole thigh. So if you knock off your profunda femoris, you don't get an ischemic foot, because most of the leg and foot come from the superficial femoral artery, but the profundus feeds the femur and the hip and all that, and that's where you can see all the nutrient vessels that feed the femur and the thigh. So with a femur fracture, there's always a chance you could get an arterial injury, and you can see here the shaft is hitting the artery right there, and they can knock off the pulses of the foot. So I think it's, I sometimes forget to feel the pulses. I just assume it's there. Have you guys ever had an arterial injury from a femur? Have you guys ever had an arterial injury from a fracture? Have you? What was your experience?
It was an old proximal humerus fracture. The lady was like in the ICU forever.
Just one thing is I'm taping everything, so just, okay, so you know we're going to be posting it.
They said, oh, she's not going to be an operative candidate, and then a month later decided that she was an operative candidate.
Proximal humerus fracture?
Proximal humerus. So we went in, opened up, and it was like super swollen. Thought there was all this hematoma from the fracture, and unplugged it, and it was just, and
a month out?
The shaft of the humerus had eroded into the brachial artery.
Oh my God!
And created this huge pseudoaneurysm. So plugged the hole, and Mark Gons came in and saved the day.
Wow.
Yeah.
That's a pretty interesting story.
Yeah, it's crazy.
Yeah, I had a.
So just sternal stone, and she did okay.
Yeah, fortunately they're rare, but when they happen, they're disasters. I had my story once was at GBMC. I had a supracondylar fracture, And this was in the beginning of my practice when I thought I was Superman. And I used to do all super condos because I did a pediatric fellowship. And the ER attending said it's got radio pulses are normal, neurologically normal. So I was like driving my office. I was like, let me just swing by to see this little kid, make sure that that's the case. It wasn't. He had a pulseless extremity. And to make a long story, it's a very long story, but basically the artery was stuck into the fracture. So I had to open it, take the whole thing apart. And of all things, so I was stuck here. It was 5, 6 in the morning. By the time I was looking at the artery, and I had a pulseless hand in a child, and I'm looking at this artery that is 2 millimeters, and I didn't know what to do. What do you do? So I was just calling for help. So remember Peter Gullicky? He just happened to walk past the OR, GVMC, and the nurse goes, "Peter Gullicky's the vascular surgeon." I was like, "Get him in the room, get him in the room." So I was like, "Peter, you got to fix this artery." He said, "No, you got to transfer it to Hopkins." I was like, "Peter, if we transfer it, the child's arm's going to die. We just got to fix it right now." He didn't even have his loop, so what he did is he took one of the nurse's reading glasses, put his face in the wound, and repaired a 2 millimeter artery. And the kid did great. It's like Peter Gullicky was totally the hero that day. Yeah. Okay, so other nerves of the thigh are the sciatic nerve in the back, and usually the peroneal branch is the one that gets injured because it's tethered at the fibula and also at the top. So it's usually the peroneal branch that gets injured when you get a sciatic nerve injury, and the femoral nerve in the front, which goes to the quadriceps, and then distally it's just superficial after the quadriceps innervation. So I'm showing you this. This is a pudendal nerve palsy. So excuse me to show you the female genitalia, but this is the only image I can get that shows you a pudendal nerve palsy. So when you nail these femurs, the post is right up against the pudendal nerve. And if you get a pudendal nerve palsy, it's a disaster because you can't feel your vaginal area or your penis, and you can't feel your anus, which is, big problem. So that's the whole point, is to remember that you can get a pudendal nerve palsy and to do things not to get that. Do you guys have any tricks? I'll tell you mine, but.
What are D and C? What are they standing for?
Those are just other dermatomal distributions, but A is a pudendal nerve. I mean, my trick is as I crank it out, I reduce it, and then if it's going to be a difficult case, I let go of the traction and then reapply it when I'm reducing it. If I think it's going to be a quick case, I just leave it on and just do the case quickly, so that it's not, say if it's a 2 or 3 hour case, I don't have the traction on the whole time. Do you guys have any other, do you guys do anything else similar to that, or how do you guys manage?
The well-padded post is important.
Pad the post. It already has foam on and soft roll. Okay. This is just a muscular anatomy. We don't have to go through this. So the muscular anatomy of the thigh is mostly the quadriceps, and then medial it's the adductors, and posteriorly you have the semitendinosus, membranosus, the hamstrings, and the biceps femoris. And the only thing to remember about that is they deform the fracture, so you just remember where the muscle groups are. So this is a World War I image. So it used to be before World War I that if you fractured your femur, there's 80% chance you would die. Then the British Army came up with the Thomas splint, and the Thomas splint decreased that morbidity from 80% to 20%. So that's kind of amazing. So you're going to say, well, what's a Thomas splint? There's somebody, he has femur fracture and they're moving him and he's in a Thomas splint. This is the Thomas splint. This round thing goes all the way up into your buttocks and groin. So you put your foot in there like a sock. And then this, your foot ends about here, and this is past your foot. And then you just take the foot and pull on it and tie it to a rope right here. So it's basically a traction device to pull your leg out, so your femur's just not moving in the wind, but rather it's undergoing traction. And this simple device decreased mortality tremendously from 80 to 20%. So that is very similar to what we have now, which is the hair traction splint. So it's almost the same thing, except at the very top we just have a strap here, and at the very top there's just like a pad for the buttocks, but it's the same concept. And you attach the foot to the end, and then you track on it with a little winch right here, or winch. So this is what they use now in the emergency room. But that always, I think I almost never see it in the. They take it off when they get to the ER because the ambulance drivers wants to keep it because it costs probably like $250, so they take it off. So, has anybody here treated a fracture with traction?
The old days.
Yeah,
You did?
We did that before.
You did that, Don Juan?
Yeah.
What was your policy? How long would it take? How would you guys do it?
3 months.
3 months
Yeah.
in the hospital? Okay, I did one case in residency. It was a 10-year-old, and we had him in traction for 30 days. Yeah, he was great. He was like he was the mascot of the orthopedic service. We always used to like seeing this child, and he healed fine. But just so you get an idea, there's some pull upwards and some pull straight, and that gives you a resulting vector straight. And then we constantly used to get X-rays, and we could change it a little bit and put a little bit more weight. But that was, for me, that was 1993. That's the last. When was yours, Bill? Around that time, right?
Yeah, about that time.
Okay, so when did people start? So now when you think femoral shaft, everybody thinks, I think, nails, right? You nail it. So where did it come from? It came from World War II in Germany, specifically in Finland, where there was a German orthopedic surgeon, Gerhard Kuntscher, and he started nailing femurs around 1942, and he published it in 45. And he was getting the German soldiers back to the front in 2 weeks or 3 weeks. He'd stick a nail in them, and they'd get back to the front. But the Americans would sit in bed for 3 months, and they maybe wouldn't even get back. And they first saw it from Americans who came back as prisoners of war that had their femurs nailed, and they saw this new device, which is incredible. And the Germans kept it secret during the war, and it was a straight device, and it worked with a 3-point bend. And here's the Kunstner nail. It's a cloverleaf shape in the middle. Kunstner died in 1972. And the Wikipedia says he died at his desk at the age of 72. So classifications. Does anybody here use the OA classification for femurs? What do you guys use? Just bad? Just simple or bad? All right. So the Winquist classification has to do with the butterfly fragment. So I put a little butterfly for you guys to remember. And here's Bob Winquist. 0 is no comminution. 1, there's a tiny butterfly. 2, greater than 50% of the cortex is intact. 3 is less than 50% of the cortex is intact, so there's not much cortex touching each other. And 4 is a segmental comminution. But we usually just say bad or not bad. So the key thing I remembered is if anybody comes through with a femur fracture, probably a 95% chance they're going to get a CAT scan. So the minute they call you, I'll say, make sure you include the femoral necks in the CAT scan. I think that's the one thing I learned from this reading today. And it's really easy for them to get the CAT scan. Do you guys do that, or usually, huh?
Just X-ray.
Usually just X-rays, but it's a freebie. So just say, make sure you extend it to the femoral neck when they do the CAT scan. And the reason is you can have a femoral neck fracture which goes undiagnosed with a femoral shaft fracture. And it's a big problem. It'll change the way you manage it. So there's 3 types that people describe femoral neck fractures. One that's completely non-displaced, one that you missed it and it's non-displaced and you catch it post-op in the recovery room, and then the third is a displaced one that you catch. So basically the femoral neck takes precedence over the shaft because you'll get avascular necrosis. So first you should fix the femoral neck with whatever you think, and then deal with the shaft. So the most common thing I think is people do these sliding hip screws and then put a retrograde nail. But if you already have the nail in, you can just miss the nail with these screws. Do you guys have any comments or? Okay, keep going then. So where do you start nails? So the most important thing with these femoral shafts is approximately what does the metaphysis in the head look like? Because that's going to change what you do, probably. So if everything's intact and the fracture is below the lesser troch, you can use a first-generation nail. But if it's not, you may have to change whatever you use. Use a cephalomedullary nail, a second-generation nail. It depends on your approach. And the starting point should be right here in the piriformis fossa. And the reason for that is that's dead center. If you draw a line of the femoral shaft up into the hip on both AP lateral views, dead center of the femoral shaft is the piriformis fossa. So that kind of guarantees you where your nails start. But if you use a cephalomedullary screw, the nail, there's a little curve there, and you use the tip of the greater trochanter. So, Bill, what do you use? Do you use for femoral shaft fractures? Do you always use first generations? Do you use gamma nails or cephalomedullary nails? Plates usually.
I've been using the Synthes long ream nail for
just primary first generation ream nail.
pretty much, yeah.
As long as the troch's intact. How about you, Mark?
Standard femoral nail.
Standard primary first generation nail. Okay, so the other issue is somebody too sick to nail? So in the 80s, there was a concept that you can't take this patient to the OR, they're too sick, they'll die on the table. And Larry Bone studied this apparently when he was a fellow in Parkland, and then he went to Buffalo where he's still the chairman there. And the people actually did better if they're nailed within 24 hours. So there were less time on the vent, less time in the ICU. People did better if you nailed them quickly. Not emergently, but quickly. So that kind of changed the way that people would think. And then the question is, do you ream or do you not ream? So the pros of reaming is the nail won't get incarcerated like this puppy. There's a higher union rate if you nail it, and the reasons are probably there's some kind of factors from nailing it. The bone graft within the hematoma goes into the fracture site, and you can place a larger nail. Does anybody have a policy of how big of a nail you use, or you just use a 12? Reps usually just say everybody uses a 12. They've gotten better. The metallurgy has gotten better now, where I think it doesn't make a big difference. You don't have to use a 15 nail or to get a bigger distal locking screw. Bill, do you have any policies or?
I tend to ream until I get a little bit of cortical chatter. It could go up to 15.
So you just go until you hear chatter.
Usually,
Make sure you get a big nail.
13, then I don't need to keep reaming, but.
So 13 or chatter.
Certainly in a tibia, I will.
Yeah, if you get a lot of chatter, then you know that you may ream out the femur, which is not a good thing, and also causes. So the cons we talked about: chatter causes thermal necrosis, takes time, and while you're reaming the femur, you're inserting fat embolism. Did you guys ever see Winquist's ultrasound of the heart during a reaming? You ever saw that? It's a great video. It's shower every time you pass the reamer. They had like a little mark on the ultrasound. And you can see the showering of fat into the heart. It's amazing. It'll change the way you think about reaming when you see that video.
How about the configuration of the femur? If you have a mid-shaft fracture, for instance, do you ream or put your thing in compared, so that you have more cortical contact above and below the fracture?
I always ream. I always put in big nails and I always ream. So I just prefer having a bigger nail, I think. Okay, so fat embolism is a problem. Here's some fat in the lungs. And the problem is having the fat in the lungs, the fat also brings cytokines or all sorts of factors that sets off ARDS or a pulmonary contusion. So the issue is, if someone already has, does reaming the nail cause ARDS? And I don't think that's the problem. I think the biggest issue is that if you already have a big pulmonary contusion, reaming it will make it worse. The fat embolism will make that contusion even worse. So patients with pulmonary contusions probably should not ream. So I don't know. I think in my mind the answer is you got to ex-fix these people. So do you guys have any thoughts on that or pulmonary contusions?
Yeah, that's the board answer.
Ex-fix, yeah. And then the other answer is you just do a non-ream nail. I think a non-ream nail is probably not good for that either.
You have to stabilize their pulmonary status before you go reaming.
Yeah. Okay, so the biggest issue I think everyone says is you have to resuscitate the patient before you nail it. So that means either blood or whatever. So the next thing is damage control orthopedics. What is it? So this is the USS Cole after it was a big hole. So you can see a big hole in the side. So you can't, the concept is you can't just fix the hole, because first you've got to get the ship back to port and then lift it out of the water, then you can fix the hole. So the first order of business is not fixing the hole, the main problem, but rather get back to port, whatever you need to do to get back to port first, and then you can fix the hole. And damage control orthopedics, Andy Pollack said that it came from Andy Burgess. He used to call it damage control orthopedics. But if you think about it, all it is basically put an X-fix on if the patient's sick. But damage control sounds like, you know, we're sailors or soldiers or something. It's kind of, it makes it fun. So basically it's X-fix. So with an external fixator, the fracture is out to length, which is great. The artery won't be kinked. You won't have a vascular injury. The fracture is not rattling around horribly, so you don't have this terrific pain. And then every time you move the patient, they don't get like fat embolisms, or they don't shower their lungs with problems. So these very sick people should get X-fixed. So if people have a serious abdominal injury or serious pulmonary injury, if you delay nailing of the femur, it reduces mortality. So this is what we're talking about. And then, so then the next thing is, do you leave the X-fix on or do you nail it? I think I've treated many. Do you guys have any thoughts about that? Do you guys just leave the X-fix on, or you nail them, or haven't thought about it?
And once they're stable, then you can go nail them.
Like a week later. Yeah, so 5 days to 2 weeks, bring them back and nail them. There's always a chance that you get an infection because now you have this hole out the skin, but apparently the infection rate's really low. So how do you guys nail them? Jack, do you do it free? And do you do a free, antegrade, retrograde, or lateral position, or supine position?
Mostly I try to do it lateral position.
Lateral? On the fracture table, or just free lateral?
On the fracture table. I've done it both ways. I think it depends on if you got a big fat patient.
You use a HANA table when you do that? The HANA has the attachment for that. How about you? What do you do, Mark?
It's a regular fracture table.
Fracture.
If they're a big fat person, then have a full retrograded.
If they're obese, what do you do?
Retrograde, have a low first.
Retrograde through the knee with the triangle. How about you, Bill?
Supine with traction.
Supine, antegrade with traction. Okay. Yeah, I usually do supine, antegrade with traction. That's how I was trained, but I think I'm going to start doing more laterals because I think it's better for obese patients, for difficult cases and for obese patients. But this is what we have here. So the other key point is adduct the femur to make sure your nail will go down. Otherwise, you'll be hitting the arm and the chest all the time. The lateral position, I think, is easier for obese people because you don't have to fight the soft tissues of the buttocks. And I think it would be easier when the proximal femur is kicked up because you can move the leg easier. You're not fighting gravity. And we have this capacity here with the HANA table. And then the other option is retrograde through the knee. So Mark, how would you treat this patient? What do the x-rays show?
Type 3 femoral shaft fracture and a pelvic fracture.
How would you treat the tail fracture? I just asked that out. All right. So reamed versus unreamed. I always put a cat picture just for fun. Reamed versus unreamed. The reamed femurs have a much higher incidence of unreamed, of union. So there's 5 times greater of non-union if you don't ream. So the thought, I think, is all those factors of hematoma go into the fracture site and help it heal. So it's kind of an interesting statistic. 5 times is pretty significant. So have you guys ever seen this? These balls? They sell these plastic balls, and you can like do gymnastics in it. You can run on a lake. They're pretty cool. There's these huge plastic balls. So you're gonna say, Spiro, why are you showing me a huge plastic ball? It's like crazy, stupid. This ball is 2.5 meters in diameter. So it's a very big ball. This is the exact curvature of radius of the femur. So if you took a human femur and laid it on that ball, it would lay perfectly. So I think this is great because it gives you an image in your mind of the bow of the femur. The femur's got a pretty significant bow. The curvature of the radius of the femur is 120 is 120 centimeters, which is 1.2 meters. That's the curvature of radius. So the diameter will be 2.5. So they sell these balls, they're 2.5 meter diameter balls. So you can think about it. It's a pretty significant bow, and the nails are less than that. Most of the nails have a less of a curvature diameter, so they're straighter than the bow of the femur. So the nails are straighter. So you can see here the bow of the femur, and the nails are straighter, which tells you that they'll come out the front. So you have to be very careful of that. What do you guys do to avoid that? Do you have any tricks? I'll tell you what I do. I make sure I get my distal. What's that?
Just make sure your guide wire is centered.
Yeah, I get it center. I try to get it center as I can in the knee, and with the hope that that'll drive everything where it should be. And I always check the lateral. I've definitely come very close with that. I've never broken through, but I've come very close with that tip is just sitting at the very anterior cortex. So the average curvature of the femur is 120, and most nails are between 150 and 300, so they're much less. So that means it's a bigger ball. So you can imagine if it's a bigger ball, it's less of a curve. So I just thought that. So here's what we usually are. So it's a pretty good sized curve for femurs. So again, the starting point for a straight nail will be the piriformis fossa, and try to get it dead center on the lateral. It's a problem if you don't get it dead center. So if you get it posterior, you'll break through the posterior portion of the femur, which is a big problem. If you're in the piriformis fossa, which is dead center on the lateral, you're good. If you're anterior, you can burst as you drive the nail down, you'll burst the top of the femur, and then it's a big problem. So what causes the deforming factors? When in the ER, the femur is nice and straight, but then when you get on the table, the thing's totally kicked up and crazy looking. So rule number one is you have to yell at the anesthesiologist to make sure they're totally paralyzed. Usually you have to yell 3 times, and it takes about 20 minutes, and then they realize you're serious. And they'll have to intubate and make sure they're sedated. And then what pulls the femur? The gluteus medius and minimus abducts it, and then this is the iliopsoas. If it breaks off, it doesn't deform it, but if it doesn't break off, it kicks it upwards, and then it's a real hassle to reduce. And then the adductors pull on the femoral shaft as well. So do you guys, when the thing's totally kicked up, what do you guys do? Bill, what do you do when the femur's totally kicked up? Proximal femur's kicked up and gives an anterior bow. What tricks do you have for everybody? So we said...
I was trained on the crutch method.
Okay, so use a crutch
and,
to push the distal fragment anterior.
Yeah, and I also bow my guide wire so I can steer it across the fracture site.
Right, but you got to reduce the fracture because you can't nail it in that position. It's got.
I usually have one guy pushing down and the
with a cob.
pushing up.
You push down with a cob, maybe the proximal femur with a cob.
No, just
with your hand.
My assistant pushing down on the anterior thigh and then the crutch underneath.
Okay.
On the distal thigh.
Okay, so just manual pressure.
Right.
Front and top
and
of
then I
that.
get the guide wire across.
All right. What else? What other tricks? How about anybody use? How about you, Mark?
You can. That's a good way to do it.
Okay.
If not, you can, like you said, just open it a little bit.
Cob and push it down. What other things? You got to have all these tricks. You know, you can't just have a jump shot. You need to have a dunk, layup. You have to have a little different shots. Turn around. What else is in your armamentarium?
Well, you can actually use the rod as a joystick if you have to.
So the things deform, and you just rod it. You don't reduce it. You just ream it proximally in a weird position, and then they have a reduction tool, which is like a little rod, and then you crank it up, and then pass the guide wire and reduce it like that. That's another option. The other option is get a Chance pin from the in our hospital. It's the femoral distraction kit. They have a 6mm Chance pin, big pin. Just drive it into the proximal femur and then use it as a joystick. So that's another option that you can do. And the other option is just totally open it up and just reduce it with those big bone clamps and just put a clamp on it. And it's better to reduce it and make a big incision than do a small incision and have a horrible reduction. Does anybody else want to add anything to that? This is all
Once in a while, you get a little butterfly that's actually in the canal, and you can be trying to push it. It looks great. It just keeps smearing off, and then you have to open it.
Yeah. Yeah, that's a problem. Well, the other thing, what I usually just open it enough to stick my finger in it, and then see if I can reduce it and feeling it with a little clamp. Okay, and I use a cob. Okay, so lateral position. Here's a Blumensatz's line. So you want to get a good lateral, and then go a little bit anterior to that, and make sure you're down the center of the femoral shaft on the lateral view. And then the AP view is kind of intuitive. And here's the hole that it will create. Looks like a total knee. And the problems, the downsides are, have you guys had any complications like that? Malunion is possible. Knee pain is possible. Patellofemoral joint pain. You get all this blood into the knee joint. That can't be good for the knee. So I guess you rinse it out and drain it. Anything else? Anybody?
I'm surprised at the lack of knee pain.
Yeah, I retrograde. Whenever I've done a retrograde, they've done very well. They're usually women with total knee replacements. I mean, I've probably done like 10. But the other reason to do retrogrades is if you have ipsilateral tibia and femurs, you do them at the same time. And it's also a supine position, so it's easy. Okay, so Mark, how would you handle this case? This is a 42-year-old man with a femur and an open tibia. You can't say, hey, send it to shock trauma.
Just what you said.
Huh?
Retrograde and tibia.
Okay, so retrograde. Now, would you consider X-fixing it and then putting it on the regular schedule, or would you rather do it immediately?
I think you can do it either way, but it's open tibia. So.
Yeah, so you got to at least wash it out. Okay. Personally, I think if I saw this case, I would X-fix it, wash it out, and do it during the day when I'm relaxed, and I have a good team, because I get really irritated at night. But okay, so in this case, the retrograde is very helpful. And you can. The other trick for the is if you have a condylar split, you have to fix that first before you nail it. So I get CAT scans on everybody just to make sure the condyles aren't split. So this is what happens if you don't get a good starting point. Usually what happens is the starting point is excessively lateral, and you aim it too medially instead of going straight down the pike. And what happens is you get this varus deformity. And you can see this starting point was too posterior, and it could have fractured it, but it caused this deformity, which is, it's a big problem. This is a difficult case, though. So the other issue, I don't know if you guys ever think about it, is like, does it make sense to jam a 17-millimeter hole into the gluteus medius attachment? Isn't that not good for the abductors? And this actually has been studied, and it was a great study where they prospectively studied the piriformis fossa starting points and the tip of the greater trochanter starting points. You would think the tip of the greater trochanter starting points, they'd have abductor lurches or they wouldn't walk well. They did just as good as the other group, completely. So there's no difference what your starting point is. What do you think, Megan? Have you taken care of many femur fractures and they have abductor lurches? Do you think that's not true, or?
I think in general, femoral fractures, any hip issue, you're having huge abductor weakness anyway.
Mm-hmm.
So I think it's a problem regardless.
For everybody, okay. So the other risk is non-union. I mean, non-unions, usually the treatments take the nail out and put in a bigger nail and ream. And the definition of a subtroch that we use is within 5 centimeters of the lesser troch. The other thing is distally, do you guys have any policies? Always lock, never lock? Lock if it rotates. What are your policies? Bill?
I always put in at least one screw.
So you always statically lock?
Yeah, it's such a chip shot. I mean, it takes 3 minutes.
Right.
How about you, Mark?
I mean, I would say I probably lock more than I don't lock, but I've definitely had,
I mean, I saw some stuff coming in from shock trauma where they weren't locking them distally.
Where they were not?
Yeah, the real long ones, proximal shaft, they just got good press fit. Let them walk, and I'm just not that bold.
Right. Some people say if you put it, if you have like an intertroch, say, and you put it long, and then if you move it, yeah, and
Right.
there's no benefit of
I
locking
get
it.
3-point fixation down the shaft.
Right. I think it's just lazy. I just lock. I freehand lock them. It's just a, I don't know, machismo thing that I can do it. I'm going to do it.
And they say that one screw is sufficient, that 2 or 3 doesn't make any difference compared to one, and biomechanically, but one does make a difference over none.
Right. So do you just do 1 or 2? What do you guys do? Just 1?
I base it on also where's the fracture relative.
If it's really close and it's very distal,
Right.
definitely put 2 or 3 or whatever. Yeah. Yeah, I do the same thing. All right. Any other comments or questions? Anybody want to say anything? All right. Thank you very much. That's femur fractures.
Excellent as usual.